for this introduction, and thank you for inviting me to speak here. Of course, we as rheumatologists, we have actually limited experience with regenerative therapies. Very few of us who are actually using it, and thanks to my orthopedic colleagues, I've become more introduced to these therapies. So the process of replacing, engineering, or regenerating tissues or organs to restore or establish normal function, that is regenerative medicine. And mainly we focus on function. Just like you in orthopedics, you decide on whether to do a joint replacement surgery when you focus on the function of the patient mostly. So Aristotle actually first described the use of bone marrow for restorative procedures, and our orthopedic colleagues have been way ahead of us in using bone marrows in surgical treatments or reconstruction and for spinal fusions, and also for the use of PRP. So they have introduced us to this use. So I've just divided my talk into two brief sections: PRP, use in rheumatology, and also stem cells. So what is the function of the platelet? I'm just going back very much to basics first. If you look here, this is the bone marrow where you have the megakaryocyte and the proliferation undergone under the effect of thrombopoietin. And you see the platelets in the vascular sinus. You have the pro-platelet, which has these long arm-like structures. And platelets are actually little bits of cytoplasm where these arm-like things shear off. And the platelets actually do not have a nucleus. So what is the function of the platelet? When we think of a platelet, we're thinking about thrombosis, stopping bleeding, etc. The platelets are powerhouses. They have many functions, which actually I did not know about in medical school at all. So when we look at the platelet, there's no nucleus, but they have these dense granules, and these dense granules are responsible for the power functions, such as production of ADP, ATP, 5-HTP. And the alpha granules produce a lot of factors which are responsible for thrombosis and clot formation, such as fibrinogen, 1 millibrand factors, thrombospodin, factor 5, as well as many other proteins. So platelet-rich plasma itself, I'm just going to get rid of this view of my speakers. So platelet-rich plasma itself has many growth factors, which it has, such as platelet-derived growth factors, fibroblast growth factors, epidermal keratinocyte, etc. And all of these are responsible for cell growth, generation, and repair of various structures such as blood vessels, skin, keratinocytes, and other tissues. So what happens to the platelet when it gets activated? It's a complex process. When there is an injury, leukocytes as well as platelets are attracted to the site of injury. And we think about injury as the platelet just going there and plugging, causing sort of adhesion of the platelets to each other and forming a plug. But in fact, they release many factors in the area. We already talked about the coagulation factors. But besides that, the alpha granule releases more than 400 proteins and inflammatory mediators as well. Now, it works, the platelets work together with the leukocytes. If you think about it, in the site of injury, the platelet and leukocytes together also have immunomodulation. So at the site of injury, they're working as have anti-infective or anti-infectious properties as well, which is something we don't think about the platelets as being part of the immune system. So here we see the platelet is, it's activated. We see that it releases fibrinogen and fibrin. Also, it releases the growth factors we talked about, such as TGF-beta, vascular endothelial growth factor, etc. And these are responsible for cartilage matrix synthesis, cartilage repair, chondrocyte production. But here, very importantly, we see that the platelets downregulate harmful cytokines and proteases. They decrease interleukin-6, TNF-alpha, and this is very important for its anti-inflammatory effects. So it's a simple procedure. Everyone here probably is interested in regenerative medicine is familiar with. We take the blood, we spin it down, we get the supernatant fluid, and that is injected in the joints, and it can be injected either under ultrasound or directly blind. So from the orthopedic literature, we have a lot of studies where platelets have been injected into joints and being used for osteoarthritis, better than placebo. There's also been a meta-analysis from quite a few years ago comparing PRP to hyaluronic acid with very good results. The WOMAC scores, IKDC scores have all shown some improvements as compared to hyaluronic acid. So we can think about this as an option. The previous speaker had already mentioned the Marspel classification of PRP. So when we're using PRP, we need to know what we're doing. What are we actually injecting into the patient? Is the method, is this patient, M stands for method, is it a handmade or machine? Is it an activated platelet or not activated? There's some controversy about which is better method. Is it an activated or not activated? Is it red blood cell rich or poor? Is it one spin or two spins being used? The platelet numbers, and these vary enormously in commercial kits. I've used commercial kits myself, and we check the platelet numbers before and after spinning down. And they can be from anywhere from 2 to 8-fold platelet concentrations, but it may not be that we need very high platelet concentrations as we previously thought. I stands for whether it's image guided under ultrasound or not. Leukocyte concentration, again, there's some controversy as to which area we should be using leukocytes, in whether it should be leukocyte rich or poor concentrations, and whether they're light activated or not. In rheumatology, we're looking for anti-inflammatory properties, and we get plenty of this without even paying much attention to whether it's leukocyte rich or not, because of the anti-inflammatory cytokines which are being released from here. So the previous speakers had already alluded to the richness of the orthopedic and osteoarthritis physiology or pathophysiology. So osteoarthritis is not just wear and tear of cartilage like we thought. On the picture on the right, this is osteoarthritis cartilage, where we see a huge number of inflammatory cytokines being released, such as TNF-alpha, interleukin-1, and we in rheumatology have produced drugs in rheumatoid arthritis to block TNF, to block interleukin-1s, to block all of these pro-inflammatory cytokines. So the use of platelet-rich plasma would be extremely useful in osteoarthritis, not just from a regenerative perspective, but because it has these huge anti-inflammatory properties which are useful in orthopedics. So with Dr. William Morell and I, this was when my interest started, we collaborated to write a paper on the regenerative treatments to enhance orthopedic surgical outcomes. So in surgery, in orthopedic doctors also using platelets a lot in tendon repair situations, Achilles tendons, and using it for shoulder injections and elbows, etc. So we in rheumatology see very inflammatory tendinitis. This is from an ankle of a person who has an Achilles tendinitis as a result or part of ankylosing spondylitis. And you see the Doppler is so highly positive. And this kind of very inflammatory tenosynovitis, which we see, maybe it would respond well to PRP, but we don't actually have any papers or evidence on this. So initially, I looked for where PRP may be used in patients who had more synovitis than we are seeing in orthopedic patients. So we looked at the Haemophilia literature, where PRP has been used a lot for the chronic synovitis. So patients with hemophilia who have recurrent bleeds have these kind of huge effusions composed of blood and a lot of degradation in their cartilage, and a lot of disability as a result. So I looked at this paper from Buenos Aires, where the patients were treated with PRP injections. It's not only improved their synovitis, the PRP injections, and improved their hemophilia joint health scores, VAS scores improved, but also decreased the joint bleeding episodes. I'm also pleased to say that Dr. Ashok Kumar referred him a case with a young doctor who had a very swollen ankle. He was completely disabled. He's a hemophiliac. He was completely disabled by the swollen ankle, which prevented him from walking. So Dr. Ashok had injected PRP with HA about 6 months ago. And the patient who's now stuck in America, he's trying to do his residency in the States. he reported back that he's not just walking well now, he's running up and down stairs and had an amazing recovery with just one injection of PRP, and it was more than 5 months ago, I believe. So going on, we, sorry, we started injecting patients with rheumatoid arthritis. So, we have rheumatoid arthritis. We have amazing drugs now. We have the biological drugs. We have JAK inhibitors. And some of these drugs right now are being used for treatment of COVID patients when they have the cytokine storm, the interleukin-6 receptor antagonist at Actemra, baricitinib, which is a JAK inhibitor. So many of our drugs are being used. So we have great drugs, but we still have patients with persistent inflammatory arthritis, which doesn't subside. And then we've usually traditionally referred them to our orthopedic colleagues for synovectomies, and sometimes even yttrium injections have been used. But we decided to start using PRP in these patients. So I just wanted to just talk about a couple of patients. This is and this was actually published in the case reports in Rheumatology. We had 4 patients. We have more patients now, but we're not reported them yet. So this young woman who did very well on methotrexate and on a JAK inhibitor, Janus kinase inhibitor called tofacitinib for 2 years, low disease activity. Her DAS28 scores were very good, but her right wrist, she had persistent synovitis despite intra-articular steroid injections, despite oral steroids, she was just not responding. So her VAS score was 45, her DAS28 score was 3.45. So her ultrasound showed this. She had grayscale synovitis. We see that over here. And she also had a lot of positive Doppler, grade 2 Doppler, where it covers about 50% of the joint area. So, and multiple carpal erosion. So this is typical for us with our rheumatoid patients in the wrist. So here is an example of the carpal erosions. So we injected her with PRP. We injected only 2 ml of PRP and evaluated her 6 weeks later. She actually had a very good response. Her VAS scores, her pain scores dropped to 15. Her DAS28 scores less and dropped to 1.45, which is clinical remission. And her ultrasound picture had also improved. Her grayscale synovitis had improved, but most importantly, her Doppler had improved vastly. So Doppler improvement to us is a very big indicator of improvement, because Doppler being positive leads to more joint damage. The second patient was an Indian female. Similarly, she had been on multiple biological drugs, you name it, Humeira, Actemra, Symphony, everything. But she had pain in both knees. Now, she is a rheumatoid arthritis patient who had almost grade 4, I believe, osteoarthritis of the knees with no synovitis or synovial hypertrophy. She was injected with PRP, even though this was more of an secondary osteoarthritis, and she did well. She did well for more than 12 months. Her VAS scores were her pain was very, very good, and all of these were with a single injection of PRP. My third patient, again, a 35-year-old lady with rheumatoid arthritis. She had failed multiple drugs, and she was on Humeira, which is adalimumab, an anti-TNF, and methotrexate. And she actually had some effusions and synovitis in her knees, not responding to steroid injections, not responding to other modalities, not responding to oral steroids. And she had a mild Doppler positive, but synovial effusion was there. So she got 4 ml of PRP in each knee, and her synovial effusions reduced. The synovial hypertrophy also reduced from grade 2 to grade 1, but clinically she felt much better. And the fourth patient I won't go into, because again, she is a last stage osteoarthritis with underlying rheumatoid. So some of these patients could delay their joint replacements. Both patient 2 and 4 clearly need joint replacements, and they're just not willing to go. We're just humoring them while they go, but they're getting significant pain relief from PRP injections. But I mean, clearly they do need to have the injections. So this is some area I'm interested in where, we've not yet tried this, enthesitis, where we, as I mentioned before, the Achilles tendon insertion, you can see on the right side, the ankle has so much swelling at the Achilles tendon insertion. And when we place a ultrasound on this, we see a lot of Doppler signal, we see calcification, spurs, enthesites, and enthesophytes at these sites. And I think these kind of patients would benefit. But these kind of patients, I would be referring to orthopedic doctors to inject, because we are not, as rheumatologists, good at injecting the Achilles tendon. We inject other tendons, but not the Achilles. So just going on briefly to stem cells, I just wanted to divide it into hematopoietic and mesenchymal. Hematopoietic, though not strictly in the regenerative world, It's something which we have used for many years in conditions where there's refractory lupus and refractory scleroderma. There's ablative chemotherapy, just like if you were doing leukemia treatment and bone marrow transplant of hematopoietic stem cells. We've used this for refractory scleroderma patients. There's a patient with very bad scleroderma, and there has been a lot of improvement in hematopoietic stem cells, which are introduced intravenously into these patients, and patients are followed up. And so these patients have failed standard high dose treatments with cyclophosphamide and other chemotherapy agents. So what about mesenchymal stem cells? I'm going to just skip over in the interest of time. You all know about this, but the mesenchymal stem cells, Dr. Ashok already talked about what they are, but from our point of view, there's so much of immunomodulation properties here. And as rheumatologists, we have not really looked into these or how they can be used in our multi-system conditions with many comorbidities in our patients. So one of these studies is they took umbilical cord tissue and they derived secretome. Secretome is a group of proteins which has actually a lot of anti-cytokine properties and other anti-inflammatory cytokines, which are very, very useful. So this patient, this was a treatment in mouse models of arthritis. Here you see the paw of a mouse with inflammatory arthritis, and the histology showing actual inflammation and pannus. And when injected with these secretomes, they develop from umbilical cord stem cells. So they actually took out the actual active part or the actual anti-inflammatory cytokines from the umbilical cord stem cells. The pannus disappeared and the arthritis was resolved. This has not been tried in humans. Now, injecting intravenously mesenchymal stem cells, this has been tried only in countries like Iran and China so far. So in Iran, they looked at patients where they gave them autologous bone marrow derived mesenchymal stem cells intravenously. And things like DAS28 scores, which is what we use to measure rheumatoid arthritis activity, VAS scores, ESR, and rheumatoid factors improved. But the drawbacks of these studies were they were not compared well to standard therapies, the biological drugs, to methotrexate, etc. Similarly, in ankylosing spondylitis, there's a lot of excess of not only TNF, but also interleukin 10 and TGF-beta. So in China, they did what they did is they took the mesenchymal stem cells from healthy donors, and this is an allogenic stem cell bone marrow aspiration, and they gave these mesenchymal stem cells, they cultured them, the proliferated mesenchymal stem cells were then injected intravenously at weeks 1, 2, 3, 4. Here they actually were able to look at MRI correlations. Bone edema was much less in the treated patients. They did not have a good control group, but patients did show clinical improvements in ASDAS scores, ESR, fatigue, stiffness, number of swollen joints, CRP, etc. So patients did well, even up to 20 weeks. But again, we have great treatments now. We have biological drugs, but perhaps these could be cheaper treatments for patients in the long term. They've not been studied further. Lupus is another multi-system disease. In China, again, they've looked at umbilical cord mesenchymal stem cell patients and patients who had active and refractory lupus. Initially, they did this study where they just injected it, but they didn't really have a good control group. These patients, they showed improvement, but they continued to be on their active treatments. But then they learned from this, and they then injected patients in severe and refractory lupus. They injected them intravenously with these umbilical cord derived mesenchymal stem cells and showed a lot of improvement in lupus markers such as SLE scores, proteinuria, urine protein, serum creatinine. And here they were able to show that cyclophosphamide treatments, even patients with cyclophosphamide or without cyclophosphamide, even if patients were not on standard therapies, they improved with mesenchymal stem cells. And that was quite interesting to see. So, I mean, that's something which could hold out hope for a lot of patients with lupus, especially ones who don't resolve with standard treatments. So this is where we are. We have some indications of benefit for chronic synovitis in rheumatoid arthritis, which does not respond to our standard treatments. We might not need to do synovectomies anymore. Hematopoietic stem cell treatment we've been using for a long time, but mesenchymal stem cells are at a very nascent and early stage of treatment for rheumatoid arthritis in small and very limited trials. And that's all we have in rheumatology. We're babies in this field.
So thanks for excellent presentation. You have three questions from the attendee.
Okay.
One is in rheumatoid, you are using leukocyte poor PRP.
Yeah, there has been no studies in rheumatoid arthritis, so we have been using leukocyte poor PRP.
And what is the difference between